The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Welcome to today's webinar, and thank you for joining us. My name is Emily Durender, and I am Chief Scientific Officer at Upthera, and I'm also the co-chair of Live Smart Texas. Today's webinar is co-hosted by the Michael and Susan Dell Center for Healthy Living at the UT School of Public Health in Austin and the Live Smart Texas Coalition. The Dell Center's vision is healthy children in a healthy world. Before we get started, I will just go over a few housekeeping announcements. First, this webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. And if you have any questions during the presentation, please enter them into your questions chat box, and we will have plenty of time for Q&A at the end of the presentation. And I'm excited to introduce our speakers today, starting with Dr. Bertha Hidalgo. Dr. Hidalgo is an associate professor with tenure in the Department of Epidemiology at the University of Alabama at Birmingham. She holds degrees from Stanford University, the University of Alabama at Birmingham, and the University of Southern California. Her research focuses on health disparities related to COVID-19, cardiometabolic diseases, with a special focus on Latino populations and genomics. Dr. Hidalgo has a strong record of peer-reviewed research published in high-impact journals, including Nature Scientific Reports, Diabetes, and American Journal of Public Health, with 65 publications in total as lead, co-author, or senior author. She has research funding from the Robert Wood Johnson Foundation, the National Institutes of Health, the American Heart Association, and internal funding from UAB. Dr. Hidalgo is the past chair of the Minority Affairs Committee and is currently on the board of directors for the American College of Epidemiology, as well as a member of the NHLBI Board of External Experts. Dr. Hidalgo is also the recipient of the 2019 Robert Wood Johnson Foundation Early Career Achievement Award. And most recently, Dr. Hidalgo was awarded funding for the American Heart Association Institute for Cardiovascular Precision Medicine to increase the prevention of cardiovascular and cerebrovascular disease in millennial women with underrepresented ethnic and racial groups. Also joining us today is Vanessa Castro with It's Time Texas. And Vanessa has been working in health and wellness for 10 years and has focused in outreach and community engagement in Central Texas for the past 6 years. She works for It's Time Texas as the director for the Stronger Austin program. Heidi Swartz will also be joining us today, and she is the executive director of the Cowtown Marathon in Fort Worth, Texas. With Heidi's direction, this event has nearly tripled in size since 2004, with over 25,000 participants and 7 races taking place the last weekend in February. In 2006, she created the Cowtown Marathon's associated nonprofit, Children's Activities for Life and Fitness, which in the past 12 years has provided over 430,000 pairs of running shoes to disadvantaged children, along with greatly reduced entry fees for the Cowtown Kids 5K run. So with that, I will now hand it over to Dr. Hidalgo to start her presentation.
Thank you so much for that warm welcome, and it's a pleasure to be with everyone on this panel and everyone watching and listening today. So thank you for having me. Let's get started with some science, and then we'll go into some of the guidelines for being able to resume physical activity in a safe and enjoyable manner. So next slide, please. I think before people are able to embrace and adapt to guidelines, it's really important to understand the science behind what it is that we're dealing with right now. What's foremost in our minds is the SARS-CoV-2 virus, which has mutated over the last year and a half to now a Delta variant, which is highly transmissible, and that is really making many of us question exactly how safe certain activities are. And so to start at the beginning, I think it's important for us all to understand that the SARS-CoV-2 virus, the original virus that we saw circulating early 2020, is part of the coronaviruses family. So there's, if you can imagine an umbrella or a family of viruses, the SARS-CoV-2 virus sits within that family. And the virus causes COVID-19. COVID-19, it doesn't mean that it's the 19th disease or the 19th virus. It simply was labeled 19 at the end of coronavirus disease or COVID because it was discovered in very late 2019. Next slide, please. And the way that this virus is constructed is that it's made up of a small set of genes surrounded by a fatty lipid molecule. So if you can imagine kind of like a little layer of fat, and then inside are the genes that make up this virus. The fatty covering is an important consideration when we're thinking about how to battle or how to get rid of the virus, especially if it's on surfaces and so forth, because the fatty bilayer means that you can dissolve it with soap or detergents. So that means that anything that has a soap or detergent in it is going to be effective for getting rid of this virus on surfaces, but also on our hands. That's why very early on, you may have heard a lot about hand washing. If you go into a gym or if you go into clinical settings or if you are in schools or workplaces, besides some of the other mitigation strategies that are recommended, hand washing remains one of the ones that is really important, because if you sneeze or cough into your hands or grab a doorknob and happen to get any virus on your hands, washing your hands or using the hand sanitizer with at least 60% ethanol makes sure that it gets rid of any virus that may be hanging out on your hands or any other part of the surfaces that you're thinking of touching or that may unintentionally touch without knowing. Next slide, please. Okay, so this is now a demonstration of how the virus gets into our cells. So if you can imagine the virus as a key, right? So we use keys to open doors. The SARS-CoV-2 virus uses what we call ACE2 receptors all throughout the bodies. The ACE2 receptors are located on multiple organs of our body, and the ACE2 receptors are kind of the doorways that allow the virus to enter the cells of our organs all over the body. And so if the SARS-CoV-2 virus is the key, then the ACE2 receptors in the cells are the doorways, and together they work to be able to allow this virus to enter the cells and cause damage, right? And actually this aspect of the science of how the virus enters the body is what was used to design the vaccines that we now have readily available to us to help us protect ourselves against viral infection. Next slide, please. So when the virus enters through those doorways, the ACE2 receptors, the virus immediately starts to replicate. And when that happens, it's causing damage to the cells. So what you may feel as an infected individual is all of the symptoms that you hear about, like fever and fatigue and headache and respiratory symptoms. And the reason why is because these ACE2 receptors, or these doorways, are located in organs like your lungs, your heart, your brain, etc. And so what that means is that you have symptoms that are representative of the damage or inflammation that's happening in your body at the time. What we also found out is that a lot of people who are infected with the virus lose their sense of smell and taste. And so this is actually a really common symptom that we heard a lot about early on in the pandemic, still to some extent now. And what's happening, though, is that there is damage in the olfactory epithelium. So like the lining of your nose and mouth on the inside, there's damage that's caused to that. And that leads to the temporary loss of taste and smell that's common to COVID-19. Now, temporary is kind of subjective because there are people who have lost their sense of taste and smell for 6 to 9 months. And there are people who, when they regain their sense of taste and smell, have different senses of taste and smell. So foods that they once enjoyed before, they no longer enjoy because they simply taste and smell different. Next slide, please. So it's important to remember that the damage that's caused when the virus enters through those ACE2 doorways, ACE2 receptors, and causes damage to your lungs, your heart, your pancreas, your intestines, your liver, your kidneys, your brain even, can lead to things like brain fog, respiratory problems. Some people with COVID-19 who are very sick end up with kidney dialysis. So it's really important to try and prevent infection at all if possible, but that if you are unable, that you understand the science so that you know exactly what's happening and why. Next slide, please. So I mentioned that the original virus, SARS-CoV-2, has mutated over time. The reason why is because anytime that the virus spreads from person to person, we are giving it an opportunity to become more efficient at infecting humans. The virus is kind of like a couch surfer. It's just looking for a place to stay and sort of like continue to live and have fun, right? But its version of fun is not our version of fun, because for some people, infection with the virus makes them really sick. Some people end up hospitalized, and of course, some people do die as a result of having infection with, especially now, the Delta variant, and subsequently developing COVID-19. And so it's really important that we consider just how infectious this new variant is compared to what we were seeing last year. So the Delta variant is really highly transmissible. That means that the people who are infected with Delta have about 1,000 times more virus in their nose and mouth and throat than the people had who were infected with the original virus. Because of this higher viral load, it takes less time for people to be infected. So before, you used to hear exposure was about a 15-minute window. If you were near someone who was infected for about 15 minutes or more, then you were considered a close contact. But now we know that with Delta, infection can happen in a matter of seconds. The vaccines work great to provide the protection against severe disease, hospitalization, but also death against Delta. And it's really the best tool that we have at the moment in order to prevent severe disease, hospitalization, and death, because what it does is it primes your body to be responsive to the virus once it sees it, so that it doesn't have to start from scratch, right? You're training your body to have the immune response to immediately respond when it sees the virus, especially because so much virus is going to be coming into our bodies from someone who's infected with Delta. And we don't have a lot of the original variant circulating anymore. So if you're going to be infected in this time frame, or if you have been infected, the likelihood is that you're going to be infected with Delta. So some people say, well, we've heard a lot about breakthrough infections, and what does that mean? So breakthrough infections are more common when there's a lot of virus in our communities and a lot of people are infected. But breakthrough doesn't necessarily mean that you end up hospitalized or that you die. It means that you may test positive, you may not have any symptoms, and in the majority of cases, actually, the vaccine helps you really like manage the infection in a way that allows you not to get super sick. Some people that have not a lot of immunity, even with the vaccine, or are immunosuppressed or immunocompromised, in those people, it is likely that even if they're vaccinated, they may end up in the hospital. But this is not as common as if you are vaccinated and healthy and so forth. So it really pays off to be vaccinated, especially with Delta circulating. Next slide, please. And so the ways that the guidelines recommend, CDC and WHO, Centers for Disease Control, and the World Health Organization, that you work to prevent the spread of COVID-19 is to wear a mask to protect yourself and others, Stay at least 6 feet away from other people who don't live with you. Avoid crowds and poorly ventilated spaces. The more people you're in contact with, the more likely you are to be exposed to COVID-19, especially in areas where there's a lot of virus circulating. And currently, because we do have access to vaccines, if you have a lot of virus circulating, you don't have a lot of people who are vaccinated, the chances of you being infected if you're in crowded spaces or very social is going to be a lot higher. And so you are recommended to get a COVID-19 vaccine when it's available to you. Washing our hands is really important, not only to prevent COVID-19, but because there's other things like strep throat and influenza and common cold viruses, all which you can also pick up with your hands as you're navigating your daily life. And they can cause co-infection, right, with Delta. And so you don't want another infection on top of what you're already dealing with if you do become infected with Delta. You want to avoid close contact with people who are sick. If you're not wearing a mask, you need to cover your cough or sneeze with a tissue and then throw the tissue in the trash. And then, of course, clean frequently touched objects and surfaces daily. If someone's sick or has tested positive for COVID-19, you want to disinfect those frequently touched surfaces. And then, of course, monitor your health daily to make sure that everything's feeling okay and you're still taking care of all of the other things that your body needs, like regular check visits to the doctor and so forth, medications for hypertension or whatever it is that you deal with on a normal basis. Next slide, please. So you're thinking, this is supposed to be about physical activity. Why do I need to know all this? Again, I think it's really important to understand the science in order to be able to understand why the guidelines exist and where they came from. So one example is the 6-foot rule, which is really great for outdoor activities. So a lot of what we've learned over the last year and a half or so is that the way that the virus spreads is through both aerosols and droplets. So there are like multiple sizes of mucus and saliva that come out of your mouth and your nose when you sneeze, when you talk, when you breathe. And the smaller ones that contain virus inside of them sort of seem to like hang in the air. The droplets, though, they're a little bit bigger. You can see these when someone is talking and there's light shining from behind them or on the side of them, either outdoors or in a classroom. And inevitably, when we speak, many of us will sort of emit some saliva that comes out. When someone's infected, there's virus inside of that saliva, or the little tiny ones that we can't see that are called aerosols. And so the 6-foot rule was developed because science experiments determined that the larger droplets could travel about 3 feet out from when the person was speaking or talking or singing or what have you, and that they would drop to the ground, right? So if someone's at least 6 feet away, then the likelihood that some of those droplets would fall on them, that they would be breathed in by the person was a lot lower. So the idea was that if you're standing about 6 feet away from other people, the likelihood of being infected if someone near you is infected was going to be a lot lower. Next slide, please. However, this changes when you're indoors, and this is why the recommendation for wearing masks indoors is so important, is because the airborne transmission, so when we emit those smaller particles that sort of hang in the air, that means that if you're in poorly ventilated spaces, even if you are 6 feet away from someone, if those particles are sort of accumulating in the space, then it's likely that you're going to breathe those particles in, and that if someone is infected in that room, because Delta is so highly infectious, which means they have so much virus in their body at any given time, then the likelihood that you're going to be infected is higher. And so if people are wearing masks, then that really reduces the likelihood that the person who's infected is going to emit virus into the air, but also that the person who's not infected will breathe it in. So the airborne characteristic of this virus is a really important component as we think about the activities that we're going to do indoors. So for example, if you want to go to the gym, if you want to exercise with a friend in a home, that you think about the way that this virus spreads, which means if you're going to be doing something that's heavy activity and you're going to be breathing a lot faster, but also a lot heavier, that means not only do you have an opportunity to emit a lot of virus, but if you're uninfected, because you're breathing heavier, you're also taking in a lot more and sort of bring it into your lungs a little bit easier. Next slide, please. So masks are really important for indoor activities. They really need to fit well around your face. You need not a super tight seal that it's cutting off your circulation, but you need something that's not going to create a lot of gaps around your nose, around the sides of your cheeks, and really underneath your chin. And so there are a lot of great masks, like surgical masks, cloth masks that you can insert a filter into. You want something with at least 3 layers. So if you have a 2-layer cloth mask, you can put in a little PM 2.5 filter, and that makes it really well and comfortable even for doing activities that require a lot of heavy breathing. And you want something that sort of curves around your nose so that you have a good fit. If I wear glasses, they fog up, but when I wear my glasses and I have a good tight fit around my nose, that really helps. Next slide, please. So some people will say, well, I may be in an area, or I may be going to a place where no one else is going to be wearing a mask. Is it enough that I wear a mask? Yes, masks work best when everyone is wearing one, obviously, but if you're the only one who's wearing it, then we talked about the concept that how much virus comes into your body is really important, right? And so that means that if you're wearing a good fitting mask and it's, at least that 3 layers or 2 layers with a little filter inside, then it helps decrease the amount of virus that's coming into your body. And that's really great news for you, because that means that your natural immunity combined with the immunity you created specifically for the virus, if you're vaccinated, is going to immediately jump and get started and get rid of that virus that's come in, that's the real virus that's going to attack your cells and really create some damage. And so what you want to do is make sure that, yes, even if you're going to be the only one, if you're going to be indoors, if you're going to be in a crowded space like the mosh pit of a concert, or you're going into a bathroom at an outdoor event, that you try and wear those masks. The masks trap that saliva and those aerosols that contain the virus in it. So it's not the virus that's sort of free floating freely in your body. The virus is contained within those wet particles, the droplets and the aerosols, and those are the ones that get trapped in the mask. And so wearing a mask helps trap from the outside, but also from the inside, and it really helps decrease the infectious dose. Next slide, please. So, is there evidence of outdoor transmission? We know that so far, outdoors is best. It's the safest way to partake in activities with people who don't live in your same household. But there have been some examples of places like the Watershed Country Music Festival, the Electric Zoo Music Festival, and then the Cornish Music Festival and Surf Festival that have happened. These are just 3 examples where there were cases that were linked back to these outdoor events. Why were they linked back to these outdoor events? Often there's a lot of singing and yelling and so forth that happens, right? It happens when people are facing each other. So if you're, as I mentioned, in the mosh pit, sort of in the middle, right up on the stage, or anywhere else around where you have a lot of people in your face, and if someone happens to be infected, it's possible that that person would infect you even if you're outdoors, because of the proximity that you have with that other person. Other places that people don't think about when you have an outdoor event are things like concessions, if they're indoors, or bathrooms, or shared buses, or anything that puts a lot of people together unmasked in a really closed space. So those are considerations if you're going to be outdoors. If you're going to be outdoors and you're running or you're biking and you're by yourself, you don't have to worry about that. There's not risk in sort of whizzing by somebody as you pass them in the park or so forth. Really what you want to worry about is that really close proximity that you're going to have with people outdoors. Indoors, the risk is pretty great, especially in light of Delta, but outdoors is safer. Next slide, please. So there are a lot of things that we went over today, and I want to be respectful of time to give time to the other panelists. But what I want you to think about is that it doesn't just take one thing in order to help bring the level of transmission of the virus down in our communities. So every action that you take is incremental, right? It all builds up to your overall risk. So if you're vaccinated and you wear a mask and you wash your hands and you do all of the things that are required and or recommended to try and decrease that transmission in our communities and keep yourselves and your loved ones safe, then the likelihood is that you can continue to do a lot of the things that we consider quote unquote normal in ways that will continue to decrease the risk for transmission of the virus, and that we have both personal responsibilities but also shared and personal responsibilities that add up so that we can work together, because we're all part of the chain of transmission, to try and bring down these levels down and allow really fun and engage in events that allow us to build community and camaraderie with people in our communities, and that bring a lot of fun back into our lives, right? So keep those elements in mind. Outdoors if possible, masked if it's going to be crowded, definitely masked anytime you're indoors. And then of course the vaccines are really safe, effective, and free, so consider those as part of the prevention strategy as well. I think that's my last slide. Let's go to the next one just to make sure. Yep. Thank you so much for your time and attention, and we'll resume with Q&A in a bit.
Hi, everyone, and thank you for that presentation. That was really helpful for myself to even watch. My name's Heidi Swartz, and I'm the Executive Director of the Cowtown Marathon based in Fort Worth, Texas. We have approximately 25 to 28,000 participants in a normal year. This past year, we actually moved our race to May and reduced the capacity. But when we did that, we had some different things that we took into consideration as we planned for our May event and as we plan now for our race that will take place in February of 2022. Can we go to the first slide, please? One thing which was just presented to you so helpfully was ways to make your event a safe event, and by doing that, looking at the different factors that there are. So for example, 3 factors to help you to make a safer choice is if you're outdoors, obviously it's going to be safer than indoors. If you're 6 foot away from people, in smaller groups, then maybe a mask is not as necessary. But as if you're in a big group, like for example at a race, when you're starting, if you've ever run a race and you're in a corral with 1,500 other people, you probably are going to want to wear masks. And then obviously the time factor, that was more of a determinant when it was the first COVID. But now that it's the Delta variant, obviously that might not be as much of a factor. It's any time that you need to take in consideration. But most important is if you're really close to people, to wear masks, even if it's outside. And we did take that in consideration as we planned our May event. Can we go to the next slide, please? So we looked at this when we started planning, and we went by the 2 out of 3 rule. So if you're outdoors and you're not near other people, you don't need another mask. But if you're outdoors and you're close to people, you don't have distance around people, then you definitely do need a mask. Or if you're indoors, you need a mask. So when we were planning our event, that was the #1 thing we looked at as we determined what we were going to do with regards to our event. Next slide, please. So as I said, our event is normally in February. For our 2021 event, we actually moved it to May and took in that 2 out of 3 rule into consideration in all of the planning of our event. Next slide, please. So what we did is, like I said in the beginning, we normally have 25 to 28,000 runners participate. For our May event, we didn't. We limited our capacity of our participants to only 6,500 runners because we just didn't feel comfortable with it being bigger than that. And we actually had a permit from the city to allow us to have 16,000, but we as an organization decided that that was just too much for us to feel comfortable with. So we limited the participation to only 6,500. Normally at our event, we have approximately 8,000 children running with us. So we did not offer our children's run in person. We made it so it was a virtual run, or we would go to the actual different schools throughout the Metroplex and put on individual little runs for every school. We knew that there was no way we were going to be able to social distance 8,000 children and make sure that they all kept masks on when they were in close proximity to each other. So we just eliminated that distance altogether. And we eliminated our longer distances, our marathon and our ultra, and only kept the 5K, 10K, and half marathon. And we did that because we chose to keep our start line open for approximately 2.5 to 3 hours. And we knew if we offered the ultra marathon, which is a 31-mile course, or the marathon, which is 26 miles, we would be, closing streets for 10 and 12 hours, and it would gridlock the city. So we eliminated those longer distanced events and just kept the half, the 5K and 10K. And by doing the start line for being open for 2.5 to 3 hours, every runner had a time printed on their bib. And that time was their start time. So normally when you go to a running event, everybody starts at 7 a.m. or everybody starts at 7:30, and you're in possibly corrals. For example, we do corrals of 1,500 runners per corral, and we start every corral 4 minutes apart. Well, we couldn't do that this year because we knew that we could not social distance people in a corral, because usually they're together so much closer than that in these corrals, that we just gave runners a start time. And we told them to stay in their car until 10 minutes prior to their assigned start time. And then from that point, then they would walk to the start line, and they would be wearing a mask until they took off and started. And so our course was open for 2.5 to 3 hours, so we could accommodate everybody's different start time. In addition, we did not do our water stops as we have done them in the past. Normally at a race, water stops are cups sitting across a table, and volunteers hand the water to the runner as they go by. We didn't want that exposure, the possibility of aerosol getting into the cups from the volunteers or for the runners. So we asked runners to carry their own water. So they carried it either as a hydration vest or a hydration belt. And we provided refill stations with limited cups in case there was a runner that really needed water and chose not to carry anything. We wanted to make sure they had the hydration that they needed, but we needed to do it in a safe manner. And so the volunteers that did those refill stations were masked up, they were gloved, they had face shields, and they refilled the water that way. We also did not distribute the goo or food products along the course. It was all provided to the runners in their packet, and they were told to carry it with them. We also did not allow spectators at the venue. We didn't want any added people. We just wanted to be able to control the 6,500 runners, not an additional 12 to 14,000 spectators. And normally when runners come across the finish line, it's a great festivity of celebration where volunteers are putting medals over runners' necks, and we didn't want that close proximity. So all medals and food were distributed to the runners in a plastic bag that they got off of a rack themselves, so that there was nobody handing them anything, nobody being face to face to them. We also eliminated the reunite area. Once they finished the race, they went through, they got their food, their medal, and they went directly to their car. There was no party, there was no reunite area. We eliminated all bus shuttles because we didn't want people to be in close proximity in vehicles. So they all had to find their own way to the start line. They had to find their own way back to their hotels or to their homes. And the relay shuttles were not offered this past year. The runners had to drive themselves to their relay exchange points. And we did not do a gear check area because we didn't want that close contact with people, because gear check's normally done in an indoor setting. We also did our packet pickup as a drive-through packet pickup, so we eliminated our expo completely. So, I mean, it was like a completely different race. It was one we've never done before. We'll probably be doing some of these things in 2022. As far as the medical course protocols were, we changed those quite a bit. So we always have medical every 1.5 miles on the course. We also have cyclists on the course that are medical, EMTs, paramedics, and then we also have medical that are in vehicles. Those hotshot vehicles normally would pick up a patient out on the course and take them back to our medical tent at the venue, but we didn't want them to be putting them into their vehicles. So we changed that, where if they got to a patient out on the course and they needed medical assistance, we just had the local ambulance come and pick them up and take them directly either to a hospital or back to our medical tent. But we didn't want to put our medical volunteers in a situation where they were in close proximity to somebody that could have COVID. So we eliminated them shuttling them back and forth. And then we also required all runners to wear masks prior to the start line. And then after they came through the finish line, there were volunteers standing there handing them masks, because we needed them to mask up once they came through that finish line, because they were going to be in close proximity to volunteers and other runners as they were trying to leave the area. So next slide, please. So we also did a lot of signage. I can't stress enough how important signage is everywhere. These signs that you see here were 8 feet tall by about 3.5 feet wide. So they were definitely visible, and we had them throughout the venue, reminding everybody that they needed to wear masks, that they needed to stay 6 feet apart, that they needed to stay in their car if they arrived early. So it's just, the more signage and directional signs that you have, the better off you're going to be as far as putting on an outdoor event. Next slide, please. This is an example of where the runners stood. So if they had a start time of 7:20 in the morning, they went to the staging area. And this staging area was a large parking lot that we fenced off, and we placed cones 6 feet apart from each other and instructed runners to stand by one of those cones. And then they just moved from cone to cone until they got to the start line. And this was a great way for us to be able to make sure that we kept the runners socially distanced in a safe manner, and they weren't put together real close in an area. And in this area, they were also instructed to wear masks. So next slide, please. And then this is the finish line. After they ran their race, depending on which distance it was that came through the finish line, they were still really spaced out in this finish line because of the way we started them with their assigned start times rather than corrals. And then what you can't see here is right after they cross the finish line and they catch their breath, they're handed a bottle of water and a mask. And that's where they're instructed to put the mask back on. And they kept those masks on all the way through until after they exited the venue. Next slide. So as far as our volunteers, we normally have 4,300 volunteers. We didn't have that many this year. We had more, about 2,000. But with volunteers, we need to make sure that we are keeping them safe too, but we're also making sure that they're not coming and they're infected and infecting our runners. So they were all sent out a questionnaire prior to race day or prior to the day that they were volunteering, and they had to answer all of the questions. If they answered yes to any of the questions, then they were instructed to stay home, and thank them for wanting to volunteer, but we'd rather them stay home and be healthy. And then if they did that questionnaire and they passed it and they answered no on all the questions and they showed up, we took their temperature. And we know now that the temperature, according to our medical director, isn't the best gauge because some people aren't going to have a fever, but it was just one more level that we could put in there. So we did have their temperature taken. We had the hands-free thermometers that they just walk up to and put their face up near the screen, and it would take their temperature and let us know if they were without a fever. All volunteers were also required to wear face masks and gloves if they were handing out something to the runners. And then we also provided face shields for any of the volunteers that wanted them. And then all volunteers that were working in our fluid refill station were required to wear masks and gloves. And we had hands-free sanitizer throughout the venue and then at every fluid stop along our routes. Next slide, please. The COVID protocols for our runners was similar. 10 days prior to our event, we sent out a questionnaire that they had to answer. And then we sent that same survey out to them, that questionnaire out to them 3 days prior. And if they answered to any of the questions as a yes, if they had direct contact with somebody that had COVID-19, or if they had symptoms, or if they weren't feeling well, we instructed them to please not come to run at the event, that they could run it virtually, meaning they can run out on their own time, their own route, and submit their results to us. And then we would send them their runner swag after the fact. And we told them, once you feel better, go run it virtually and we will get you your things. And then we did the same self-reporting symptoms check with all of our volunteers 3 days prior to the day of the event. Next slide, please. Now we're planning for 2022. We were one of the first races to take place in 2021 since the shelter in place, since everything got shut down. And we're the largest one to have taken place since everything got shut down when we had it in May. And now this fall, we're monitoring all these other races that are happening. We've got the Boston Marathon, Chicago, New York, all these other large marathons that actually canceled and rescheduled to this fall. So we're monitoring to see what they're doing for COVID protocols and watching them to see how things are being handled as we plan for our 2022 event, which is the last weekend in February. Next slide, please. So we don't know exactly what we're going to be doing in our 2022 event, but most likely we're going to do several of the same things we did when we did it in May. The difference is we are noticing now that, like for Chicago, Boston, New York, all of those races are requiring a proof of vaccination or a negative test within 72 hours prior to race day. So that's something that we're considering requiring to our runners too. We also will do the self-reporting questionnaire to our runners, volunteers, vendors, and staff, and we will send that out again this year, 10 days and 3 days prior to the race, just like we did last year, because it worked so well. I can't tell you how many runners actually did that questionnaire and sent us an email and said, you know what, thank you for the questionnaire, I'm not feeling well, I'm not going to come, we'll run it virtually. We will most likely not have our kids race in person again this year. Again, as I mentioned before, it's 8,000 children that participate in that event. And to social distance 8,000 children is just virtually impossible. And so we will most likely be going to their schools and putting on individual races for all of those kids at those schools, just like we did this past year. It worked really, really well. It was a way for these kids to still be able to be active and get outside and run an event, but not put them or other runners in a situation where somebody could get infected with COVID. We will plan on keeping our start line open for an extended period again this year, just probably not for as long as what we did last year. We'll probably start more runners at a time than we did last year or this past May. In May, we started 4 runners every 3 to 4 seconds. And so we'll change that this year, and it'll probably be a couple of hundred runners every 5 to 10 seconds. We will again ask runners to carry their own water and offer refill stations. We felt like it worked really, really well. We will have limited cups available, but it's twofold. One is it's making it so it's safer for the runners because they're handling their own water and we're not passing it off to them. But the other thing is it's great for the environment because we don't have thousands and thousands of cups out there on the course. Now runners are carrying their own water in their hydration vest or belt. So it's kind of a good thing that actually happened. And again, we will ask runners to carry their own nutrition when they go out for the run, and we will provide the nutrition when they pick up their packet, but then we will ask them to carry it. We will limit the spectators at the start and finish line, but we won't eliminate them. We will allow some spectators at the start finish venue this year. And then the food and medals will probably be distributed again in bags as we did last year. And we will again not offer the hotel shuttles or relay shuttles. And we will continue with our medical protocols as we did in the May event. We will offer our expo this year, but we will require runners to wear a mask when they're at the expo, or if they're in one of the tents after the race, we would require runners to have a mask on, and we'll have masks readily available. But those are just some of the things that we're planning on for the February 2022 event. Next slide, please. And then the Running USA, which is the national trade organization for running events across the United States, created this really great COVID white paper, and the link is here for you. And I would encourage all of you to go check out that white paper if you're going to be putting on an outdoor event, because it had a lot of really, really great suggestions in it. And I just can't tell you how valuable it probably will be for some of you. And if any of you have questions with regards to putting on an outdoor event, I have a whole COVID protocol policy that we have created that I'd be happy to share with anybody that was interested. And thank you very much.
Hi, so you can go ahead and move to the first slide. So my name is Vanessa Castro, and I'll be talking with you guys about how we use community voice in our transition planning. Slide. So I work for It's Time Texas. If you guys haven't heard about us, we are a statewide nonprofit, and we have various programs and partnerships across different sectors and regions in Texas. And it's all aimed at shifting behaviors, practices, and policies to make Texas healthier. Slide. So today I'll be talking about Stronger Austin. And this is our, it's a group exercise focused program, and it is very community driven. So in a pre-pandemic world, every year we'd offer on average 500 classes, and then we would serve on average about 1,000 participants. What makes Stronger Austin unique is that community-driven aspect. So we consider community voice in every decision we can to inform the program. And so that looks like what formats we decide to offer, where our classes are offered. We only offer programming that the community deems as like an accessible site. So a lot of times that looks like parks, rec centers, churches, libraries, clinics, schools. And the instructors who lead our class, we recruit directly from within the community as well. And so those people are very representative of the participants they're serving. And people that are coming to their class are their church members, the parents from their kids' schools, their neighbors, their friends, and their family. And so all of that really helps create that community feel that we try to create through the programming. Slide. So on March 13th, that's the day that we realized, okay, COVID was a reality and our world came to a stop. You can change to the next slide, please. So first thing we did was we canceled all of our programming. And then I'll be honest with you, I took a few days to just panic and I didn't know what our next move was. But as soon as I could relax my heart rate a little bit, we, around that time also, we realized, okay, this is not going to last for a couple weeks. And we started planning what our next steps would be. So after like maybe a 2-week hiatus, we started transitioning our programming to be fully virtual. And I'll be honest with you, I wasn't expecting a lot from this. We really did this just so that we could try it. In a pre-pandemic world, we didn't even have an email listserv because so many of our participants did not use email. We would communicate with our participants through like mass text. And so we were anticipating technology barriers to be like a reality. But we were very surprised. Our first class, when we launched virtual, we had over 100 people register, and I think it was about 80 people attend. And we were one of the first programs to make that transition. So because of that and because of our early success, we were able to work with a lot of other community organizations who were trying to transition to being virtual as well. Next slide, please. So after about a year, we thought it was about the right time to start thinking about the future. And so we started looking at the CDC and the local guidelines. We looked for research about physical activity and COVID transmission. We looked at all of our existing program data and really dove deep into that. We consulted with other organizations and partners who were serving a similar audience, and just to make sure that we were aligned in the way we were serving. We got input from our staff, right? Because our staff is members of our community. And so if they weren't feeling comfortable enough to lead programming, they weren't going to feel comfortable enough to invite their church members and their friends and their neighbors. And then we also did a lot of consulting with the community to get their feedback. Slide. So we consulted with the community through surveys and interviews available in English and Spanish. I would say probably 30 to 40% of our participants are Spanish speakers primarily. We conducted interviews over the phone and through Zoom, and then our surveys were distributed virtually to our current participants, but also past participants, so that we would capture the opinions of people who virtual wasn't their thing and they hadn't been coming to programming in a while. So we were very surprised with what the community shared. 61%, so majority of our participants had shared that they were either slightly or very uncomfortable in returning to in-person programming starting in the fall. Only about 30% of respondents wanted programming, virtual programming, to just go away and wanted all in-person programming. 46% of participants wanted hybrid. They wanted the option to do virtual. And then 24% of our participants were just happy with virtual and they didn't want another option. There were a few arguments in favor of in-person programming, and that was social connection. They really missed that social aspect. They felt like they had more motivation and focus in person, and then they just wanted to avoid technology challenges. And then there were a lot of arguments against in-person programming, and that included safety for themselves, for others, living outside of Boston, convenience. They thought virtual programming was more convenient, a lack of transportation. People shared they didn't want to wear a mask during exercise, and just the general uncertainty of like what COVID would look like in the future. Slide. So we also asked our community, okay, if we were to return to in-person programming, what would we need to do for you to feel comfortable attending? And majority of our participants really emphasized distance and the ability to distance through limiting capacity. About a third of participants referenced that they wanted programming to be outdoors exclusively. And then there were a lot of, mixed feedback about mask wearing, and some mentions of availability of like hand sanitizer. A common theme that came up was not allowing children at programming, and even some people were very passionate about not having to wear a mask. Slide. So some of the things that we learned were that Zoom fatigue is definitely a real thing. However, just because some participants are sick of Zoom and virtual programming, that does not mean that they're ready to return to in-person programming. We also learned that virtual programming for us is really filling a need that wasn't previously met through our in-person programming. And that's for individuals who don't have transportation, individuals who don't have childcare, and individuals who maybe they do have transportation, but they just could not commute in Austin to make it to a class on time. And then I think one of the most interesting things that we've learned was that since our transition to virtual, our program's participant demographic had greatly shifted. And so currently only 30% of our participants are in the city of Austin. And so this was really impactful because, you know, previously we had, when thinking about our community, we were thinking about the faces, the people of our participants who we knew and we would see in class all the time. But now those participants are only a fraction of the people that we're serving. And so we needed to adjust our perspective to include the reality of our larger demographic. So all of this research happened like a week before the onset of the Delta variant in Texas. So what we decided to do was, given the hesitancy from our participants, right, it was like 61% of participants were uncomfortable returning to in-person programming. We made the decision to continue virtual programming through the end of the year. And as the COVID pandemic continues to evolve, we'll continue to monitor that. And then we will also continue to engage with our community to see how they're feeling and ensure that when we do return to programming, that we're doing it in a way that is safe and comfortable for everyone involved. Slide. And that's all I have.
All right. Thank you, Dr. Hidalgo, Heidi, and Vanessa. We will go ahead and take some questions. We have a little bit of time for questions now. Just a reminder, please be sure to type your questions in the chat box, and we already have a few that are rolling in. So the first question comes from Kate Martin. We are an outdoor education organization and trying to assess the safety of having staff back in person in Austin schools. We would be outside 95% of the time, masked, and students and teachers would also be masked. Can you give us some guidance for that particular setting? Anything that comes to mind?
Perhaps I'll start. I think the science supports outdoor activities very nicely. And what is being described, I think, sounds very consistent with what the science supports, which is that the risk outdoors is lower than it is indoors. When you want to wear a mask outside, again, is when people are talking, if you have people in each other's faces. Obviously with kids, it's really hard to keep them away from each other. They're like all over each other all of the time, especially at the younger ages. And so I would say anytime you're indoors, if you are going to have indoor gatherings or people that are working indoors, you really want to make sure that those masks are tightly fitting around their face. You want good quality masks like surgical masks or at least a bilayer cloth mask with that filter inside of it. I don't recommend the N95s because those fit really loosely around most people's faces. They kind of leave a lot of gaps. Those need to be fitted to the individual face of the person that's going to wear them. So surgical masks are nice, and you can double up with a cloth mask over. And then, of course, you know, if you can ensure that the majority of people are vaccinated, that adds an additional layer of safety, because the likelihood that those individuals will transmit is lower than an unvaccinated individual. So again, this is a layered approach, right? But it sounds like 95% outdoors is fantastic. If the weather permits and it's comfortable, then I would say yes, absolutely go for it.
Awesome. And I think we have time for one more quick question also from Kate. How should vaccinated people interpret the different staging levels for risk? Is stage 5 as dangerous for vaccinated people as it is for unvaccinated?
I'm not sure I'm familiar with the stages. I think the staging differs by location. And so I would say that if there is high spread of the virus in your community, city, state, especially in your community, then your risk as a vaccinated individual is pretty high and almost comparable to an unvaccinated individual. But the risk is different, right? Because if you're vaccinated, your chances of being really sick are a lot lower, especially with Delta. So it's kind of a tricky assessment. There's a lot of, well, it depends. And so I would say if you're at a really high level of transmission, you want to put as many of those layers in place as possible. If you are in a place where, like in the state of Alabama, you're in a green community, green is good, you know, cases are low, then you can probably get away with not putting so many layers in place. But the basic layers should always be at minimum a mask, and of course, now that we have the vaccines, vaccination.
Okay. Well, thank you so much, everyone. It looks like we are running out of time, and thank you for attending today's webinar. We appreciate you being here. And remember that this webinar will be archived on our website at msdcenter.org. And thanks again for joining us today, and we'll see you next time. Bye.